So next up, continuing this theme of malabsorption, Sarah Jane Schwarzenberg from the University of Minnesota will be talking about cystic fibrosis. Thank you, Sarah Jane.
Thank you. And thanks to the organizers for having me. And how do I forward this? Okay. Cystic fibrosis occurs in about 1 in 3,500 individuals in the United States and Europe. It's one of the more common genetic diseases that we care for on a regular basis. It's caused by loss of function mutations in the cystic fibrosis transmembrane conductance regulator gene. There are approximately 1,000 genetic mutations that have been demonstrated in the CFTR. Not all of them lead to clinical disease, but many of them do, and their results are somewhat variable. The CFTR protein mediates the secretion of chloride and bicarbonate as well as water across the epithelial layer. The result is progressive obstructive lung disease that generally leads to death in the 4th decade. This is substantially improved over when I was in medical school, but it still is associated with early death. Management of cystic fibrosis generally involves maintaining pulmonary function and controlling infections. And what I'm going to talk about today is how nutrition is key in these two areas. So in the United States, cystic fibrosis is managed through Cystic Fibrosis Foundation centers. This is a somewhat unusual way of management, and it's going to influence a couple of the things I'm going to say to you later. The Cystic Fibrosis Foundation creates centers across the United States. It mandates the center personnel, and it pays each center by the number of patients it cares for each year. Approximately 85% of CF patients in the United States are cared for in these centers, and virtually all of them, after consent, have their data regarding a myriad of clinical issues sent to the foundation to a registry yearly. So this includes infections, nutrition, liver disease, pulmonary function. This information, which has now been collected for over 3 decades by the center, is available through a registry on about 85% of the patients in the United States. The center uses this data to develop QI projects. Any center can see how they compare to every other center in the country with respect to survival, BMI, FEV1, and many other aspects of care in cystic fibrosis, and that's the basis for quality improvement in this area. So we've heard that cystic fibrosis is predominantly a lung disease, and lung disease is the predominant cause of death. But what is the biologic impact of cystic fibrosis on nutrition? And it's really quite significant. People with CF require more calories than average because of increased pulmonary effort and chronic and recurrent inflammation. They are able to ingest fewer calories than average, and they lose more calories through urine and stool. This is because, first of all, they often have poor appetite and intake. They often have abnormalities of motility, diminished sense of smell, abdominal pain, and depression. And then they have malabsorption related to pancreatic insufficiency and small bowel overgrowth. They also have a unique form of diabetes and a unique form of liver disease, each of which impacts nutrition in this disease. Now, I don't have time to talk about every one of these factors, but I'm going to talk about a handful of them in detail. Pancreatic secretions are responsible for the digestion of the majority of the protein, carbohydrate, and fat we ingest. And in cystic fibrosis, pancreatic fibrosis begins in utero. Most individuals with cystic fibrosis are pancreatic insufficient at birth, and 85% will be pancreatic insufficient by 1 year of age. We try to offset this through pancreatic enzyme replacement therapy, but even when we do our very best, we're able to digest about 95% of the fat ingested, so we're not by any means a pancreas. People with CF have chronic intestinal inflammation, which is much less well recognized than the pancreatic insufficiency. Because of the defect in the CFTR, the intestinal mucus is dehydrated and thick, and it tends to stick to the intestinal lining and holds bacteria against the intestinal lining. This creates dysbiosis that is exacerbated by the repeated antibiotic use in CF. And the result are intestinal lesions, including villus damage, ulceration, and edema. This leads to diarrhea, bloating, nausea, abdominal pain, and distension. People with CF also have decreased intestinal bicarbonate. Now that seems obvious since they have pancreatic insufficiency, and the pancreas is our main source of bicarbonate to offset the acid coming out of our stomachs. But enterocytes also produce bicarbonate, and enterocyte production of bicarbonate is diminished in CF. This is important for two major reasons. The first is that absorption of fat requires the production of mixed micelles with bile acids, and bile acids do not remain in solution at low pH. And the second is that pancreatic enzymes today are all enteric coated. All the ones that we use for this purpose are enteric coated. And that enteric coat will not dissolve in pHs below about 5.5 or 6. So I'm going to show you a study that was done in a group of healthy controls and a group of CF patients who swallowed a smart pill that measures intestinal pH at several second intervals throughout the GI tract. Do I have a pointer here? I guess not. So at the very beginning on the left-hand side, the y-axis being pH, if you look at the navy blue squares, those are healthy controls. The first point that you see on the graph is the point at which the smart pill entered the duodenum from the stomach. And you can see that by point B, which is about 10 minutes into the study, the intestinal pH has gone above 6, which, as we said, is kind of where we would like for it to be. But if you look at the orange line, those are cystic fibrosis patients. And you can see that their point B is much farther down in the GI tract. They do not reach optimal pH until about 35 minutes into their transit. And that means that the time of mixing of pancreatic enzymes with food is much less for them than it is for others. Liver disease is the third leading cause of death in cystic fibrosis. It's a unique form of liver disease, a focal biliary fibrosis, a multilobular cirrhosis that can occur with or without portal hypertension. And again, the main issue for people with CF and nutrition is the reduction in the production of bile salts associated with liver disease. Intestinal dysmotility is being recognized more and more in CF. CFTR itself may directly affect intestinal smooth muscle function, but dysbiosis is a huge factor in reducing motility of the small intestine. There's an overall slow intestinal motility, but on top of that, there is gastroparesis, and this affects about a third of individuals with CF, more so as you get older, resulting in nausea, early satiety, persistent dyspepsia, and abdominal pain. So here's a group of people that we very much want to have eat more calories than average, who become full faster and who become nauseated when they're eating even normal meals. Sinus disease is common in CF. Nasal polyps are characteristic of cystic fibrosis. And this results in an impaired sense of smell and thick retropharyngeal mucus. Your sense of smell is crucial to your appetite. And when you are unable to smell food, it's harder to eat it. So there's another reason for poor intake. Cystic fibrosis-related diabetes affects about 50% of people with CF over the lifespan. It's largely the result of the loss of islet function in the pancreas. It is a catabolic state, and prior to the current era where we began screening children, sometimes as early as 6 years of age with yearly oral glucose tolerance tests, there was a decline in pulmonary function and body mass index seen several years before diagnosis. So what is the evidence for unique nutritional requirements in CF? The most common cause of death, as I said, is respiratory disease. But there has been evidence since the 80s that maintenance of weight greater than the 50th percentile for age and gender is associated with longer survival. Good nutritional management may result in an additional decade of life, which is quite significant in CF. I'm going to show you only one study in this regard, but I could have picked any one of 4 or 5 wonderful studies in order to illustrate this. This is a prospective observational study using data from the CFF registry. In this study, over 3,000 patients with CF were stratified by their peak weight for age percentile at age 4 to 5 years. They were stratified into 4 groups. Those who, at age 4, were less than the 10th percentile, 10th to less than the 25th percentile, 25th to less than the 50th percentile, and 50th percentile or greater. So they took this data, they took this stratified group of patients, stratified at age 4, and they looked at what happened to them when they were 18 years old, because that was in the registry. Patients with a weight for age percentile greater than the 50th percentile at age 4 years reached a much higher height for age early in life and maintained this advantage into adulthood. Pulmonary function, measured as FEV1% predicted, was much lower in CF patients who at age 4 had a weight for age percentile less than 10%, and this tracked through 18 years of life. And this, coming up, is the money shot. This is survival in cystic fibrosis, stratified by weight for age percentile at age 4. On the left is the proportion of patients surviving, and on the x-axis is their age in years. And you can see that the lines basically diverge at age 4 because that was the starting point of the study. The thickest black line are individuals who at age 4 had a weight for age percentile in the 50th percentile. And the bottom line are the individuals who had a weight for age percentile at age 4 less than the 10th percentile. So I think in our general population, we look to keep people on the same weight for age percentile throughout life. Many children grow on the 10th percentile, and we say, oh, that's great, 10th percentile, okay, that's you. But in cystic fibrosis, it's not good enough. You have to be at the 50th percentile or greater in order to achieve the longest life possible. CF-specific nutritional interventions are driven by the quality improvement projects of the Foundation, as well as by guidelines developed by the Foundation. Newborn screening has allowed us to intervene in nutrition very early in life, and in fact, it's well established that children who get newborn screening and who are introduced into good nutrition before, let's say, age 2 or 3 months do better than children whose diagnosis is made even that short a period of time later. Children are asked to eat a high-fat diet to increase calories and they're asked to eat 3 meals and 3 snacks every day, and it's really hard. The foundation mandates quarterly clinic visits, and each clinic visit includes an evaluation of growth and a dietitian consult. Our patients are all given water-miscible, fat-soluble vitamin supplementation because they generally cannot adequately absorb ordinary vitamin supplements. Growth failure is fairly broadly defined: low weight, losing weight, and slow weight gain. And early intervention includes high-calorie oral supplementation, behavioral psychology counseling, social services, consultation with other services such as GI and endocrine, and gastrostomy placement for supplemental feedings. People with CF also have an abnormal fatty acid pattern with diminished linoleic acid and diminished docosahexaenoic acid and variable changes in other fatty acids. Some of this is related to fat malabsorption and protein energy malnutrition, but some of it may be related to the CFTR abnormality itself. And that is a critical issue of research now. I'm going to briefly mention the fact that we now have modulators that improve the function of some subsets, some gene mutations in CF. The first one was ivacaftor, that improved the effect of gating mutations, made gating mutations less injurious. Now, that only includes about 4 to 6% of people with CF, but those people on ivacaftor experienced improved lung function and reduced sweat chloride, and they gained weight, perhaps due to the release of bicarbonate into the GI tract. So the new era of therapy is giving us new options in managing nutrition. So what are the research gaps? Okay, this is the first of 50 slides. So what is the cause of dysbiosis and dysmotility in CF, and how do we best manage it? What is the appropriate fat type for people with CF to ensure adequate essential fatty acids without increasing inflammatory products? How do we address nutrition as the patient ages and new complications occur? And what effect will these new modulators of CFTR have on nutrition? So in summary, in cystic fibrosis, better early childhood nutrition is associated with better height growth, better lung function, and improved survival into adulthood. But optimal nutrition in CF is not a simple matter of increased calories. We have to pay attention to a complex disordered matrix of digestion, absorption, and intestinal function, and that is really the challenge in this disease for us. Thank you.